Well, good afternoon, everybody. May 1st. All right, May Day. Well, listen, number one, before I begin, I just want to tell you guys that I'm proud of you. I mean, I really mean that. That's not, something I'm just saying out of the air. It means that I care about you and about your progress. So I want to hear every week when I do those conferences on Zoom. And I apologize to you for this last one, but it's new water for me. And so my fault. But hopefully this time we can get on and we can talk. So during those Zoom conferences, I would like to hear everybody, at least once. And what I'd like to hear is, how's it going? And do you have a question that you read about in the book that you just don't understand? I'll be happy to answer that. You can call me anytime. I've given you my phone number. Okay. I'll give it to you again. 760-963-0943. 0943. Feel free to call anytime. Okay. Be happy to talk to you no matter how long it takes. In fact, one person, I won't mention their name, talked to me almost for 45 minutes, and I didn't mind. Okay. Okay. The other thing I want to talk to you about is, before we begin, is be safe out there. Okay. Wear the mask. Try not to touch your mouth, your nose, your eyes. Okay. After you touch things, wash your hands first. Give you a kind of a comical example. Okay. Let's say you're working as a monitor tech in the hospital. Okay. You touch a bunch of stuff. And then all of a sudden, gosh, bathroom time. Now, the good question is, do you wash your hands before going to the bathroom or after? Before, because you have a lot of, unless I'm mistaken on human anatomy, portals of entry down there. Okay? So you should wash your hands before. You should wash your hands after. Before doing something with your patient, wash your hands. After doing something with the patient, wash your hands. Okay? You touch the floor, you touch the sharps box, wash your hands before going back to the patient. I think I told you this. I won't tell you which hospital, but who knows. Saw a nurse come in one time, and I was just visiting, and she was going to give an injection. She was going to push something in the IV. So what she did is she took the needle and a syringe, and she puts the end of the syringe in her mouth and pulls off the cap. John Wayne, and then, washes off the IV with a isopropyl alcohol, goes over and injects something in the IV. Then goes over to the sharps box and gets some new tape and touches the top of the sharps box. Now, she didn't have gloves on, which you really should do, but she touches the top of the sharps box and gets some tape. New bookshelf, top of the sharps box. That's where we put all of our sharps, dirty needles, test tubes that we want to throw away. Anything that will cut you or poke you goes into the sharps box. But people use it for a lot of stuff. Cotton balls. Listen, to throw a cotton ball in the sharps box is not proper procedure. But people will tell you, I could make a knife out of this cotton. Okay, fine. So then goes over and touches the sharps box again, puts the tape back on, tapes up the IV. She took the end of the syringe and put it on the shelf of the window. Interesting procedure. Then she has the patient get up, sit in a little chair, okay, and then goes over and takes all the patient sheets off the bed, throws them on the floor. Then goes over and gets new sheets, still hasn't washed her hands, and puts them on the patient's bed. Then takes everything off the floor, right, and throws it in the dirty linens. Then helps the patient out of the chair, still hasn't washed her hands, go back to bed. Hello. Guys, you got to think. Let me give you my 3 things. Dirty to dirty. Dirty things should only touch other dirty things. Clean to clean. Your hands aren't sterile. Neither are the gloves you're wearing most of the time. So, clean to clean. Clean gloves can touch your clean hands, right? And sterile to sterile. What does sterile mean? Sterile is anything that is free, totally free of any microorganisms. So if something that is sterile touches a clean object or even a dirty object, it's contaminated. Anytime you think something's contaminated, throw it away. Okay? When you guys put on gloves, right? If you wear gloves, like some people wear gloves on the market, right? Those gloves are not sterile. They're clean. Okay? When you're taking off clean gloves after you put them on, right? Don't go over up here on your wrist, because what are you doing now? You're still gloved. You're touching your skin with whatever you've touched. Okay? Come up here. Peel off the glove slow. Compress it with your hand here. Go under your glove with your finger and take it off. Okay? And then throw them away. Watch the nurse once. I won't tell you who. I don't even know who. She was starting IVs in one of the labs. Okay? Very good. Has on gloves. Excellent. PPE. Personal protective equipment. You guys are wearing masks now. One of the biggest things about the masks is try not to reach up and touch your face. Go back here. They're over your ears. They're back here. Okay? And if you got a mask that somebody sewed for you, cool. Wash it, because you're going to reuse it, right? Okay? So she starts the IV, does all this, then she goes over to the sink. Good move. Takes off the gloves. Good. You know what she does with the gloves? Puts them on the sink counter. Hello. Washes her hands. Good. Then, after she washes her hands, she goes back over to the gloves that are still on the sink counter, picks them up with her hand, and throws it away. We got a problem. Now she's got to start all over again. Should have threw it away the first time before she washed her hands. Couple things to think about, okay? When you guys are out there, wear the mask. Wash the mask prior to going out again. Okay? Don't touch your mouth, your nose, your eyes. I know it's hard. Just try not to. All right. So, I want to talk to you about, once again, sinus arrest, sinus block. Sinus block is nothing more than thinking, look, here's a sinus node. The sinus node is where? In the posterior wall of the right atrium. What's it do? It's the pacemaker of the heart. It sets the rate, it sets the rhythm of the heart. Impulses come out of there between 60 to 100 times per minute. Okay? Play like we've got a sinus block. Now, I like this, the block, okay? Here's an electrical impulse trying to come out of the node, but it's blocked. so it doesn't come out. The SA node is still beating. It's still initiating impulses on a block. Okay? So what are you going to see? You're going to see a pause. Guess what? If you go a couple of R to Rs before the block, and you keep going over the pause, the straight line, guess what? The rhythm's going to pick up again, exactly where it left off. Why? Because the sinus node is still initiating sinus impulses. It's just blocked. Okay, hopefully that makes sense. If not, call me. Okay, we talked about this before. I'm just hitting something we went over. Sinus arrest, sinus block is on page 48. You can go over it again. Okay? Sinus arrest. In sinus arrest, the SA node stops initiating impulses. Okay? So if you go a couple of R to Rs before the arrest, and then you go across that flat line, the pause. Okay? It's always a pause on sinus block or sinus rest. It's always a pause, flat line. And if you go over here, guess what? The rhythm is not going to pick back up again on time. Why? Because you've disturbed the pacemaker. You've stopped the pacemaker. It's going to pick back up, but not on time. Okay? Sinus arrest, sinus block are treated the same way. So I'm not going to go into this a lot. Okay? Now, we get over to something. I'm just moving in my book here, fiddling with it. Okay, your book, your main textbook. Premature atrial contractions. We've got premature atrial contractions. We've got premature junctional contractions. We've got premature ventricular contractions. PACs, premature atrial. PJCs, premature junctional. PVCs, premature ventricular contractions. Now, why would something do that? Because it's irritated by stress, by drugs. Okay, it becomes irritated and it fires. How do we know it's premature? Because we're measuring P to P. We're measuring R to R, and it happens to come prematurely. Let me talk about premature atrials really quick. Premature atrial contractions, you'll see a contraction coming early. You've got to take a look at it. Okay? Good place to do that, if you're looking, is on page 89. Okay? You go down to the bottom of page 89, strip 7-8. You'll notice 3/4 of the way through the strip, there's a PAC. Now you go, well, wait a minute. That doesn't look like a PAC. I don't see any P wave before the QRS. Take a look at the T wave. Sometimes the P wave and the T wave, if the rhythm's fast, will join the collace to what is called a PT wave. Okay? So look at the contour of that T wave. Look at all the other T waves. This is more P. It changes the contour of it. Okay? So the P wave off the premature atrial contraction and the T wave just before it can collace. Okay? And you're going to get a T wave that looks different than the other T waves before the premature atrial contraction. The underlying rhythm, and what I mean, and that's an important statement, the underlying rhythm, what comes before the premature, what comes after it, is pretty regular. Okay? It's irregular, obviously, with the premature contraction. The P wave associated with the PAC is premature, so if you're able to see it, which you usually are, okay, it's going to look different. The P wave in size, shape, and direction. Always look back to what came before it. Okay? The PR interval is usually of normal duration. But the P wave, again, can be hidden in the T. The QRS is usually of normal duration. It's 0.10 or less. And the best place to show you this again, and I'm looking at page 89, okay, on the bottom, strip 7-8. Okay. Now, P waves will sometimes join with beats, regular beats that come before it. P waves will sometimes join premature atrial contractions, will sometimes join premature atrial contractions, will sometimes join with regular beats that come before it. And here's where it gets a little tricky. If it joins with one regular beat, okay, they kind of join up, right? And it looks weird, because you have a little bit of a pause there. If it joins, you can have two types of pauses. You can have what's called a compensatory pause and a non-compensatory pause. Okay? So I'm talking about premature atrial contractions right now. If they join with a beat, that is called Gemini. Okay? Now you're going to have bi, tri, and quadrigemini. Let me get back to this pause here. Tell you where I am. I'm over on page 90 and 91. On 90, you see a non-compensatory pause. Let me tell you what happens. The premature atrial contraction happens, okay? And because it's in the atrium, it's not a far distance from the SA node, okay? Not a far way off. So what the premature atrial contraction will do in a non-compensatory pause, I'm going to stop this for 1 second here. Okay, tell you what I'd like you to do, guys. I'd like you to look over on page 90 in your main textbook. Okay, and want you to kind of look at the top strip on page 90, strip 7-9. If you take a look, we've got what appears to be, count this out real quick, okay, an NSR, a normal sinus rhythm. Then all of a sudden, take a look at that PAC. Okay, how do you know again it's premature? Because if you're doing your calipers R to R, P to P, what? It's early. And take a look at the P wave. It doesn't look like the P waves on the left, the rhythm before this, because it is premature. The P wave is not going to look the same. It can look very close, and sometimes it'll be hard to differentiate. And so if you're reaching for clues here, it may be just the prematurity, because the P waves look so close on the left to the premature P wave, PAC. It may look very similar. So it's that early beat that may help clue you. Now, notice in the middle strip, 7-10 on page 90, we have this thing called a pause. And this one is a non-compensatory pause. Well, a non-compensatory pause means this. Because the premature atrial contraction happened where? In the atrium, which is close to the what? Sinoatrial node. Guess what happens? That premature atrial contraction goes up and disrupts the timing of the SA node because it happened early. And so the SA node just stops. That's your sinus arrest. Just stops, right? And if you're going across with your calipers again, you'll notice, in fact, you can do this little experiment here. on page 710. Okay, and notice all of those R waves on the left before the premature atrial contraction march out, but then you hit the premature atrial contraction in the non-compensatory pause. Guess what's going to happen? The rhythm is not going to pick back up again on time, okay? Because this was a sinus arrest. So in non-compensatory pauses, the rhythm, if you're going across it, does not pick up again on time. If you're going right across that baseline, right into the next R, okay, after the non-compensatory pause, it's not going to pick back up on time. In a compensatory pause, it will pick up again on time, okay? So non-compensatory pauses, they interrupt the rhythm of the sinoatrial node, and the rhythm on the right, okay, the right of the premature beat, does not pick up again on time. In compensatory pauses, it does. Now, let me just jump ahead a little bit, because you're going to see this with PVCs, premature ventricular contraction. And with the compensatory pause, the rhythm after will pick back up as what it was before, okay? Which means what? It gives a little bit more time for the chambers of the heart to fill, okay? And with ventricles, what are we talking about? We're talking about preload. So the next beat, okay, preload again, remember? Take a balloon, play like this is a ventricle, but it's a balloon. Take it over, put it on a faucet, start filling it up. The volume at the end of diastole, at the end of relaxation, the volume in your ventricle, okay, at the end is going to be more. Why? Because it took a little bit more time. Why? Because a compensatory pause doesn't disrupt the timing. And so even though there's a pause, right, you'll get more volume. And the next beat will be a little bit harder, like a thud. Okay? And people feel those a lot of times. All right. Hopefully that makes sense. Now, I want you to look at something over on page 92. I want you to look at the bottom strip, strip 715. Notice that we have a normal sinus rhythm, then all of a sudden a pause. I always got to look at the pause to determine what it is. Is it non-compensatory? Is it compensatory? Okay. But then, doesn't this look funny? Looks like a little bit, bunch of little lines, okay? And that is sinus arrest, okay, in there. So it's a normal sinus rhythm with sinus arrest and an atrial escape beat. Now, when we say escape, what's it escaping? Overdrive suppression. Okay, so anytime there's a pause in the rhythm, there could be an escape beat. So remember, you've got those backup levels, right? What are they? They're little pacemakers in the atrium, little pacemakers in the junctional, little pacemakers in the ventricular that will back up the normal pacemaker of the heart and back up a pause, right? Remember what those rates are? Giving you a little hints here. Those rates of those escape beats that happen from an ectopic focus, okay? Anytime there's a pause, there can be an escape beat. There can also be an escape rhythm. If we do atrial, okay, backing up the SA node beats from what? 60 to 100 beats per minute. Okay. If we get atrial escape, it will beat from 60 to 80. If we get a junctional escape, it will beat from 40 to 60. If we get a ventricular escape, it'll beat from 20 to 40. What's it backing up? It's backups, it's redundancy pacemakers to the sinoatrial node, to the regular pacemaker of the heart. Well, here we've got a sinus rhythm, and then it goes into sinus arrest, and you get a atrial escape beat, but you can also have junctional escape beats. You can also have ventricular escape beats. Okay? Now, I want you to look at something kind of odd. Look at page 93 here. Page 93, you get a normal sinus rhythm. Then all of a sudden you've got this pause, but what is it? Okay? It is a non-conducted PAC. Now, why is it non-conducted? Because it's non-conducted because it did not find the node on the end of, okay, where does things go after they leave the sinoatrial node? They go to Bachman's bundle, okay, over to the left atrium. They go from the SA node down to the what? AV node, right? SA node, AV node. And how did they get there? Through the anterior, the middle, and the posterior internodal pathways, right? Well, guess what? The AV node may not fully be depolarized yet. Okay? It may still be a little refractory, which means what? Refractory, like resistant. So guess what? It can't conduct it. Okay? So in a non-conducted premature atrial contraction, the underlying rhythm is regular. Okay, but it's irregular when we come to the pause. The rate of everything is the rate of the underlying rhythm on the left and on the right. Okay. The P wave associated with the non-conducted PAC is premature and abnormal in size, shape, and direction. And sometimes it's hiding in the T wave, which makes it a little bit more difficult. So you always have to look at the contour of the T wave right there just before the pause, and the T waves before the pause. Okay. The PR is absent with the non-conducted PAC. Okay. So non-conducted, premature, abnormal in size, shape, and direction, the P wave. Okay. So what are we saying? You don't get the QRS. I'm looking on page 93. I'm looking at strip 716. P wave is commonly found hidden in the T wave. Okay. And the cause here, because it can't conduct, because the conduction system is a little refractory. So you see the P wave, but you don't see the QRS following it. Hopefully that makes sense. Okay. If it doesn't, call me. Now I'm over on page 97. And this is what we call atrial flutter. If you look at strip 722 on page 97, atrial flutter. Now the biggest thing that gives atrial flutter away is these back-to-back P waves, but they're called F waves, flutter waves, back-to-back. And so notice, this is a 4-to-1 conduction. 4 P waves before a QRS. But the F waves, or flutter waves, look like the teeth of a saw. The biggest thing about this rhythm is if you flip it upside down, it looks sawtooth. And the rhythm is normally regular if the conduction is 2-to-1, 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 or 3 to 1, 3 to 1, 3 to 1, or 4 to 1, 4 to 1, 4 to 1. But if you go from a 2 to 1 to a 4 to 1 to a 3 to 1, the rhythm is what? Irregular. Once again, these are called F waves or flutter waves. So the rhythm of this whole thing can be either regular, okay, or what? Irregular. The rate is 250 to 350. Now your book takes it up to 400. Okay, books disagree a little bit. The P waves are sawtooth, okay, which is affecting the entire baseline because with atrial flutter, there is no baseline. It almost obliterates these flutter waves, these sawtooth waves, obliterate the baseline or the isoelectric line. The PR is obviously not measurable, and the QRS is normal. So it's easy to recognize, guys, an atrial flutter. It's easy to recognize kind of what's going on. It's rarely seen in patients with normal heartbeats, atrial flutter. The rhythm may be due to heart failure, decreased blood flow to the heart, ischemia, abnormalities in the heart valves. It could be due to, just pick one of those. Somebody asked you about atrial flutter, you can tell them. Old age, but I won't say anything. Okay. All right. Like premature atrial tachycardia that we've talked about, okay, the ventricular rate in atrial flutter may be rapid, okay, due to increasing myocardial oxygen requirements. Because the heart starts beating faster, it demands more what? Oxygen. Okay. The cardiac workload is up and decreasing due to cardiac output. Because watch this. The more F waves you put in front of the QRS, okay, the more decreasing the cardiac output is. All right, let's see what else I want to tell you here. Well, I think I've mentioned all I want to in atrial flutter. Okay. Then we go over onto page 100 and 101. We talk about atrial fib. Okay, now I want you to look at atrial fib. And I want you to look at strip 728. Okay, so we have some kind of a rhythm, maybe before it. But in strip 728, we have in the middle of this strip atrial fib. How can you tell? Because it looks like you're running EKG with an earthquake going on. There's these little waves like this. And those are called F waves also, or fibrillatory waves. Okay. And what's that mean? It means the atrium are just shaking. They're not contracting and putting blood through the AV valves down into the ventricles. Okay, so there's no atrial kick, which means the atrium are not contracting. So you lose 30% or greater of your cardiac output. Okay? In atrial fib, if it's above 100, it's called uncontrolled atrial fib. If it's less than 100, it's called controlled. What did I tell you we might give the patient in atrial fib? The biggest thing, the biggest worry about the patient here is the blood is pooling in the atrium and it's dripping by gravity through the AV valves down to the ventricles, okay, which you lose a lot of your cardiac output because there's no atrial contraction. So if blood pools, guys, we need to put the patient on a blood thinner, even though there's no such thing as a blood thinner. Most people call it that these days. So we need to put the patient on maybe warfarin or Xarelto or something like that. Those are blood thinners. Yeah. Okay. And you can call them that because if you come up with something different, nobody's going to know what you're talking about, especially the patient. Okay. So the main thing is, if we don't put them on a blood thinner, they can have a blood clot there because the blood is pooling in the atrium. So we don't want blood clots. Why? Because the patient can have a stroke. Okay, the blood clot. The patient can have pulmonary embolisms with a blood clot. Okay, so that's just going to make our situation worse. Okay, they may also try things like to cardiovert the patient, and you can read about that. Okay. All right, see what else I see here that's interesting. Okay, so we're basically in the strips now, and I want you to fill those in, and all the answers are in the back. If you don't understand it, call me. Okay, every day you can call me. I don't care if you don't understand something. Okay, now guess where I am? I'm over onto junctional arrhythmias and AV blocks. Okay. I want you to turn over, if you can, really quick, to page 141. Okay. And I want you to look at page 145 really quick, strip 813. Junctional rhythm will a lot of times happen with an inverted P prior to it. So if you look at strip 813 on page 145, notice that P waves look what? Inverted. Why? Because the junction, the AV junction, is not getting signals from above, so it takes over as the pacemaker, okay? And it depolarizes the atrium. The atrium are up here, right? Atrium, up on top. Okay? It depolarizes the atrium from below. So instead of having upright Ps, you get inverted Ps. So a lot of times when you look at junctional rhythm, there'll be either inverted Ps or no Ps. Because you go, what is this all of a sudden? And remember the rates, 40 to 60. Okay. But remember this, you can also have accelerated rates. Okay. Meaning what? Above 60 up to 100 is accelerated junctional rhythm. Now this one seems to be in the 40 to 60 range. Right? It says it's 35 a minute. And remember, there's a couple of ways you can get rhythms, right? But if it's really slow, I would count the number of little blocks between two consecutive R waves and divide that into 1,500, okay? Take a look at strip 811. What don't you see? You don't see any P waves, okay? Why? Because the P wave in a junctional can be hidden within the QRS complex. So you go, well, how do I know? Well, you're going to have to get used to this idea that if on the rates, if you don't see P waves, and the rate is somewhere around, this says it's 47 to 40 to 60, is probably junction. Now, one more thing I need to tell you about that P wave, inverted. It can be prior to the QRS or after the QRS, you can see inverted P waves, or buried within the QRS. For the QRS, after the QRS, or buried within the QRS. So you're going to have to get used to kind of that concept on a junctional rhythm. Okay? Now, a great place to look for the P waves on this is lead 2. And I know that a lot of these strips you guys have to fill in. Don't tell you which lead it's in. Perfectly okay. Just remember, it's either going to be inverted, the P wave, or it's going to be buried within the QRS, or it can come after the QRS. And once again, if it's buried, you ain't going to see it. Okay, take a look at page 144, strip 811. Once again, you see a junctional rhythm. This says it's at 47. It sounds junctional, okay, but there's no P waves. Notice? All right. Okay. Now, junctional rhythms can happen for a lot of reasons. It can happen, now remember, the junction, the AV junction is now pacing the heart, not the SA node. Okay. The AV junction is depolarizing the atrium from below. Here it is, below. Here's the SA node. So it's not affecting the SA node, but it's depolarizing the atrium, two upper chambers of the heart, from below, AV junction. That's why you have the inverted. And the biggest thing about that is something called retrograde depolarization. Retrograde means it's moving in the opposite direction. How do the waves come from the heart? Downward and to the left. I'm not being anatomical here. Downward and to the left from the SA node. The SA node isn't pacing. The junction is pacing. So the junction is putting electrical impulses to depolarize the atrium from below. So it's going upward instead of downward to the left. Now eventually it goes downward, okay, after it depolarizes the atrium, but it's going in the opposite direction. That's why you have the inverted P. Okay, I'm moving over just a little bit. Accelerated junctional rhythm. Looking at that. Now, if you go over to page 146, I hit a word here that I want to make sure you know. 146 at the bottom, box 8-4. Okay. And 146 at the bottom, box 8-4, has a big word, paroxysmal. Paroxysmal means immediate. It means sudden. Okay. Now, it gets a little confusing, but let's try this. If you go PAT, what's that? Paroxysmal atrial tachycardia. Okay. It can be from 150 to 250. Okay. Paroxysmal junctional tachycardia, the same thing, 150 to 250. Paroxysmal ventricular tachycardia, okay, let me back up. Paroxysmal atrial tachycardia, okay, 150 to 250. Okay, just remember that. So if it's paroxysmal, any area of the heart can start beating erratically if it becomes irritated. And it can beat from 150 to 250. I'm going to stop this for just a second. Okay, let me back up a little here because I may have said something that wasn't correct. So that's why I'm backing up just a little. Paroxysmal, sudden. So all of a sudden you're sitting taking notes in class, yeah, trying to pay attention to my lecture, whatever, talking on your cell phone, no, okay. And all of a sudden, your heart's beating, that normal of maybe 72 beats per minute or somewhere around there, right? And all of a sudden you get a tach. Why? Because the ectopic focus, atrial, junctional, or ventricular, can start firing. Why? Because it's irritated. If it's just regular tach can go on, sudden tach, because this word here, paroxysmal. Sudden tach can happen between 150 to 250. Flutter, like atrial flutter, can happen between 250 to 350. Fib, now fib is hypothetical because there's no way you can really count this out unless you have some kind of an oscilloscope set up and all this kind of stuff. But fib can happen between 350 to 450. And remember, there's only two types of fib with the heart. There's atrial fib and there's ventricular fib. Fib looks like, a bunch of lines that don't make it, peaks and valleys is what I call it. Don't make any sense at all. There's no wave there. You may go, I think I see a wave. You need to get yourself another Bud Light. Okay, so paroxysmal, tach, 150 to 250. Paroxysmal flutter, 250 to 350. Paroxysmal fib, 350 to 450. Got that? Good. Okay. What does that mean? It comes on suddenly. So you're looking at an NSR and all of a sudden, bam, you hit a very fast rhythm. You got to decide, is that atrial, junctional, or ventricular? All right. Something else I wanted to share with you, I'm just looking really quick. Okay. By the way, if you can get this book, you can get it for about $5, maybe $6. You don't have to get this edition. I think this edition is $6. You can read this thing in a couple of days, cover to cover. I'm just throwing out a hint, okay? So you may not know anything about basic arrhythmia. And once you read this, you do, okay? And the only reason I say that is because I found it in 1972. I was working Northridge Hospital ER. I found it sitting around. I always had to, I was a tech. Okay. And I always had to hook patients up to EKGs. So I go, well, I wonder what this, and I found this book and I took it home. And what I like about it, I really like about it, is it's like a PowerPoint. It's a picture, a couple of sentences, question. Picture, couple of sentences, question. You don't have to think very long about what you're looking at to understand that. Okay? And it's very easy to go through. Okay, so I'm back to junctional rhythms again. I think I kind of mentioned what I wanted to in that. Okay. Looking really quick. Okay, so just to recap. The rhythm in junctional is regular. The rate is 40 to 60. The P waves can be inverted in lead 2. Remember? Immediately before the QRS, immediately after the QRS, or buried within the QRS. You just won't see any P's if it's buried. The PR is short, 0.10 or less. Okay. And the QRS is normal. Okay. Remember the PR ought to be what? 0.12 to 0.20 on PR. Here I'm telling you the PR in a junctional rhythm is usually short. Another way to identify it is 0.10 or less. The QRS is normal, also 0.10 or less. Okay. Now, why would you have junctional rhythms? Well, number one, the SA node stops pacing. So either an atrial ectopic focus can pop up, and take over pacing, or a junctional ectopic focus can pop up and take over pacing, or a ventricular focus can pop up and take over pacing. Remember, normal pacemaker of the SA node is 60 to 100. Any rhythm, any pause, anything in there that doesn't happen for a while, right? Or a very short time, right? An ectopic focus can pop up and give you an ectopic beat or an escape rhythm. Okay? They're just standing by, they're just ready. It's a redundancy system. atrial, junctional, and ventricular ectopic foci are redundancies to the SA node. Now you can see junctional rhythms with MI, particular what we call inferior wall, inferior bottom. You can see it with if your parasympathetic kicks in. Remember, parasympathetic, you slow things down, okay? Because junctional is kind of a slow rhythm, okay? So if something slows, right, with junctional, okay, if something slows down, anything that goes slower than the normal SA node, the next pacemaker will take over. You can have a diseased SA node for a junctional rhythm. That's the cause of it. Okay. Patients taking digitalis, you can see it, because what does dig do? It slows the rhythm. Okay. Positive inotropic, negative chronotropic, chrono, rate. Dig slows the rate. Calcium channel blockers, beta blockers. Beta blockers when I'm on for atrial fifth. Remember, it blocks the beta 1 site in the heart. So if anything else sticks in there that's a stimulant, it won't let it. Now we talked about blocks, right? And how many we talk about? 3. First degree AV block. Make sure you got this right down. You can look at stuff later. First degree AV block. NSR, consistent prolonged PR. So when you're looking at it, you've got a normal sinus rhythm and a consistent prolonged PR. What do I mean by that? The PR is above point what? You guys should know. 0.20. Okay? Because as much the PR goes from what? Up to 0.20. If it goes above 0.20, it is above its normal rate. Okay? So when you get to first degree AV blocks, NSR consistent prolonged. What I mean by prolonged is it's above 0.20. Okay? So look, it may be 0.24 here. That's above 0.20. It may be 0.24 here. It may be 0.24 here. Whatever you measure on a PR within a junctional rhythm, it's always going to be that same PR across the entire strip. It could occur with ischemia, first degree block, okay? Increased parasympathetic, dig, calcium channel blockers, amiodarone. Amiodarone is a drug that slows the heart rate down. Okay? Any of those, you can get junctional rhythms. Now, first degree AV block, NSR, consistent prolonged PR. It's a pretty simple rhythm. Looks like an NSR. The only thing that's wrong with it is the PR is consistently prolonged. I'm looking, guys, making sure I don't leave anything in the dust here that I should tell you. Okay, so it looks like an NSR with a consistent prolonged PR. That's first degree AV block. Second degree, that's where it gets a little confusing. Second degree, this is blocks, second degree, up here, okay? Come down. 2 types of second degree AV blocks. One is called second degree AV block type 1. I don't like all that verbiage. Call it MOBITZ, M-O-B-I-T-Z, 1. Okay. Now you can also call it, you just want one word, Winky block. Sounds like a cartoon character. Here's Winky Buck. What happens in a Mobitz 1? Very simple. The PR lengthens from cycle to cycle to cycle. Punctual P, dropped QRS. The PR lengthens from cycle to cycle to cycle. Punctual P, dropped QRS. And it happens over and over again. And they call it Winky Buck footprint. Now, you don't have to, I don't think I'm going to ask about Winky Buck footprint, but I want you to be able to identify it. Okay, we're identifying it. Take a look at page 149 on the bottom. 149, bottom strip. Take a look what we got. Strip 821. So we got a second degree block. Mobitz 1. Okay, notice everything looks kind of okay in the first, second, third, fourth, fifth beats from the left. Notice what happens then. You got a pause. Why did that pause happen? Well, let's go back to the left. Take a look at the first PR on the strip. Okay, it looks a little wide. Look at the second. Look at the third. It keeps getting wider and wider, right? Then all of a sudden, what happens? It drops. Okay? So the almost normal sinus rhythm, the PR lengthens from cycle to cycle to cycle. Punctual P, drop QRS. This is Winky Buck. Okay? All right. Now, second degree AV block, Mobitz 1, I'll just call it Winky Buck. The next block under a second degree AV block is called Mobitz 2. Mobitz 2. Here's what I'm going to tell you about Mobitz 2. Also easy to recognize. You have 2, 3, or 4 P waves prior to every QRS. Okay, 2, 3, or 4 P waves prior to every QRS. The PR of the conducted beat, is steady. It's not going to go through. So the PR of the conducted beat does go through, but hold on for 1 second here. I was trying to think of a name for the PR of the conducted beat. It remains static. It remains the same all the way across the strip. Now, not where you got the pause, but what's been going on. Okay, if you take a look down at the bottom of page 151, you see strip 8-4. What do we have? We got a second degree AV block, but I just call it Mobitz 2. Anywhere I can cut out verbiage, I want to do it. Okay, Mobitz 2. What's the conduction ratio? 2 to 1. What's that mean? I've got 2 P waves prior to every QRS. Okay, so what did I give you on the definition of Mobitz 2? 2, 3, or 4 P waves. This matches up, doesn't it? Prior to every QRS, right? Here I've told you the PR of the conducted beat remains the same. Take a look at the PRs on every one of those. Start out from the left. The PR remains the same all the way across the strip. That is a Mobitz 2. Okay. Let me go a little bit further here. Okay, now one of the biggest things I can think of here with junctional is notice the rate drops down and it keeps going way down. And you got to worry about that because what do you got to worry about in your ultimate thing? Cardiac output. Okay. So what rate? The ventricular rate. It goes way down. It's extremely slow with a Mobitz 2. Okay. So what does that mean? Cardiac output is decreased. Anything that speeds up the rate to where the ventricle doesn't have enough time to fill, and anytime you slow it down a lot, you worry about cardiac output. Cardiac output is decreased. And a lot of times with that, symptoms are present. Like what? Hypotension, your blood pressure really falls. Shortness of breath, heart failure, chest pain, syncope, S-Y-N-C-O-P-E, fainting. Okay, got to tell people that have this Okay. If they go from a lying position to a seated position, sit there for a couple of minutes. If they go from a seated position to a standing position, sit there for a few minutes. Why? Because you could pass out. The episodes of syncope, fainting, are called Stokes, S-T-O-K-E-S, Adams syncope. It's right there on page 151 on the right, in black. Okay. Now, here's one thing that's going to decrease the cardiac output, the conduction ratio. 2 to 1 is one thing. If you get a 3 to 1, 4 to 1, what are these? QRSs, heartbeats. So the higher the ratio, the better, but the higher the ratio, the not better, the worse. Okay, 2 to 1 maybe here. These are QRSs. 3 to 1, 4 to 1. Okay, notice your heartbeat goes down. That's why your cardiac output goes down. Okay, so just to recap now, when we're talking about moments 2, 2, 3, or 4 P waves part of every QRS, right? Okay. The rate is that of the atrial rate. Okay. The P waves, remember you can have 2, 3, or 4 part of every QRS. Okay, and there's sinus P waves. The PR is consistent and may be normal or prolonged. So remember the way I gave you this. What is second degree block Mobitz 2? 2, 3, or 4 P waves prior to every QRS. PR, the conductive beat, remains constant. That's what you got to look for. All right. One other thing here. This is a Mobitz 2, right? Second degree AV block, either Mobitz 1 or Mobitz 2. Mobitz 2 is less common but more serious than Mobitz 1. Why is that? Mobitz 2 can progress with little or no warning into third degree block. Third degree block has also been called complete heart block. It can also go into asystole, where you got to call a code. Okay? Does this make sense? Yeah. So you can't just go, well, they're in Mobitz 2, I see this. And I'm going to kind of ignore it for a while before I talk to the nurse. I got other things to do. No. You better tell somebody right away. With little or no warning can go into a third degree block or asystole with little or no warning. Okay? Now, if the block on Mobitz 2 is at the bundle of His, okay, then the QRSs are going to be narrow. If the block on a Mobitz 2 is in one of the bundle branches or in the bundle branches, you can have a wide QRS. Okay? Okay, now third degree. Third degree, obviously, the more you go up in degrees, yeah, the worse it gets. Okay, like first degree AV block is really no big deal, although with any of these blocks, the patient needs to be seen frequently to make sure the first degree doesn't go to a second degree, Mobitz 1 or Mobitz 2, and a second degree doesn't go to a third degree. The biggest thing with third degree is called a complete heart block. None of the impulses from the atrium, none, are reaching the ventricles. So what does that mean? The atrium and ventricles are separated because none of the impulses are coming down to the ventricles. So therefore, the atrium is usually paced by the SA node. A pacemaker, the SA node paces the atrium. And the ventricles are paced by either a junctional pacemaker or a ventricular pacemaker. Okay. And the causes of this can be a lot of things. MI, myocardial infarction, okay. Cardiac surgery, DIG, here we go, DIG again, digitalis. Okay. Or Here's an interesting one. Lyme disease. A deer tick bites you. Okay. But can be serious as far as your heart. All right, so what I want you to do is take a look down at the bottom of page 153. And on 153, we have a third degree AV block. Page 153, strip 827. Notice something. Because the atrium are being paced by a different pacemaker than the ventricles, then the P2P is regular. Now, you can't necessarily see it all the time because it hides out a little bit, maybe in the T, but the P waves, almost like a cartoon, Casper the Ghost, kind of like walk through the QRS and right out the other side. Okay? There's a completely independent rhythm of the P's and the QRSs. Now the QRSs march out, so do the P waves. But there's no relationship between P and QRS. We're the P's normally, prior to the QRS. And then there's what? The 1/10 second pause, in the QRS, in the ST segment, and the T wave, right? Here, the P waves just kind of walk right through the QRS. The problem with this is this can go into cardiac arrest very, very quickly, okay, with little or no warning. Okay. Cardiac standstill, meaning the heart's not beating, right? With little or no warning. Also called ventricular standstill. The ventricles are not beating, which means you're not going to get a what? Pulse. All right. Now, one more thing I want to tell you, and let's see if you can kind of, I know it's a little ahead, but you can kind of grasp this. Okay. If you get a ventricular rhythm, you get a rhythm that's usually between 20 to 40, or accelerated ventricular rhythm, which means what? Above 40 up to 100. That's accelerated. The QRSs are wide, deep, and tall. Let me say that again. The QRSs on a ventricular rhythm are wide, deep, and tall. Okay? Trying to find a good one here for you to look at. So, pause this for a moment. Okay, take a look at page 198, okay, and take a look down at the bottom, strip 9.5. We got an NSR, right? And all of a sudden in this NSR, what do we get? We get this wide, deep, tall complex. That comes from the ventricles, okay? And notice what's above that, compensatory pause. Compensatory pauses do not reset the SA node, okay? And PVCs, premature ventricular contractions, if it's that, are going to be wide, deep, tall complexes. Now, if we go over a little bit to say 200, okay, and go down to the fourth strip from the top, or I'm sorry, the third strip from the top, we have wide, deep, tall QRSs in the middle of a normal rhythm. What is this? This is a run of VTAC, a run of VTAC. And then notice we have the two PVCs on 911 just before the end of it. Okay, those are called pair PVCs. Take a look at page 916, down at the bottom. I'm sorry, page 202, figure 916. This is an IVR. IVR stands for idioventricular rhythm. Idio means peculiar to that rhythm, okay? In other words, if you see an IVR, you'd expect it to do this, okay? Notice we've got what? Wide, deep, tall QRSs. A lot of times you can't see the P's, but the SA node keeps beating with the ventricular rhythm. So sometimes you can see it. Okay? Most of the time, in my opinion, you can't. Why deep tall QRSs? What? A rate of what? 20 to 40. Now this rate's 41, so I wouldn't necessarily say it's accelerated. Other people may, but I'm not that particular. Notice over on page 203, we see an accelerated IVR. What's that? Why deep tall QRSs? Above 40, because the rate of ventricular is 20 to 40, above 40 all the way up to 100. If it's above 100, what is it, guys? It's V-tach. If it's paroxysmal, it's 150 to 250 tach. Okay? Now, I want you to look at something peculiar about this. Well, tell you what, I'm going to stop here. Let me grab another test here real quick. Because I want to give you some hints of what's going to be on it. Okay? But I want you to keep reading. I want you to keep reading all the way through ventricular rhythms. And I told you leave out pacemakers for now. Now, let me see if I can reach down here without falling over the chair. The next quiz. Remember I talked to you about paroxysmal? Sudden. And if rates appear suddenly, I gave you 3 of them. Know them. Okay? Know what they begin with, know what they end with. We talked about atrial flutter. There are going to be 2 types of flutter, atrial and ventricular. We talked about fib, right? And hypothetical rates. Now, I think I mentioned this, but I'm not sure. PEA. What's that? Pulseless electrical activity. So you're looking at your monitor, and you got something that looks fairly normal. You go, oh, the patient's okay. Patient's dead. Their heart isn't beating. What did I tell you a long time ago? This kind of maybe relating to a test question. Never treat a monitor, treat a patient. So what do you need to do? You need to talk to them. Okay? If they're not responding, check a pulse. PEA is pulseless electrical activity. So you're seeing some electrical activity, but guess what? That is not stimulating the muscle to contract. So you have no heart contraction anywhere. Okay? So you have no pulse. Okay? So the patient's blue, hanging over the side of the bed, whatever. Okay? And you go, yeah, you're looking at the monitor, you're focused on that. You shouldn't be. In the past, this has been called EMD, electromechanical dissociation, because there's no association with the electrical activity and the depolarization of the muscles. It looks like it on the monitor, but there is none. Now, I like to think from another book that you can have 3 types of cardiac arrest. Ventricular fib, okay. Cardiac standstill. Look, what if you have P-waves and long lines between them? What are you going to say? That's an atrial rhythm at a rate of, no, you're not. You don't have any QRSs. So what are you going to call that? Cardiac standstill. What if you have VFib? Just a bunch of wavy lines, peaks and valleys. Okay? Now there's coarse VFib, where, a bunch of peaks and valleys, very high, the amplitude of it. And there's real fine VFib. Okay? It's still a cardiac arrest. Okay? And you have PEA, pulseless electrical activity. All right? Now, we talked about blocks. Know what they are. Know how to describe a first-degree block in words, word pictures. Second-degree block, Movitz 1 and Movitz 2. Third degree block. All right. Now, a couple things I want you to know. So I expect some phone calls. Why? Because you maybe don't understand it all the way. Okay. So I expect some phone calls to come up. This is May 1st. Happy May Day. Okay. I am going to give a midterm on May 13th. And just look at that and make sure that's what I want to do. Tell you what, let's put it May 20th. And I'll give you a little extra time. What am I going to ask? Everything that I've taught you up to this point could be on the midterm, including today's lecture. Okay? If you're confused about anything, call me. And then, and I mentioned this before, but I probably didn't give the right date, so let this one stand. June 10th for the final. Okay, now the midterm and final are going to be timed. And what am I going to ask you on the final? I'll tell you when I finish my lectures. Okay? So there's going to be 10 quizzes, which you should have caught up with. And I want you to read all the way through your book. I want you to start filling out the strips. But on June 10th, I'm going to do the final. Okay? And remember what you've got to have ready. Your notebook. Okay, now let me give you a couple of other things. You're going to write what? 4-page type paper. Mostly in your own words. Okay. Yes, you can double space it. That's perfectly fine. All right. You go, well, how are you going to get those? I don't know. I'm thinking maybe everybody can buy a drone. It's okay. Your papers can also be on, I said anything on EKGs, anything on basic arrhythmia. They can be about that. But they can also be on anything I'm about to give you now, which is looking at patients, and because you don't like where they came from, you don't like the color of their skin, you don't like their religion, prejudice. And here's a couple of films that you can watch, you can order, whatever, that I think are the best on that subject. One is called Remember the Titans. It's a true story about a football team and what they had to go through. You can write on that and tell me what you think. Tell me what you're thinking here, what your final conclusion is. Okay? You can see a movie called Radio, R-A-D-I-O, Radio, not AM or FM. That's on a football player in high school and what happened to him. True story. I like true stories. You can do a 4-page paper on that. Guys, call me. I am praying for you through this COVID-19. I'm praying that none of you get it or none of your family members get it. If you want to talk to me, I'm available anytime. I don't care what you want to talk about. Okay. If you don't understand something, call me. I will take time to explain it. God bless. Have a nice evening and a nice rest of your day. Bye-bye.